So I think for the sake of time, we'll get started. So again, welcome everyone to our Feminist Health Conference. Thank you so much for joining us here today. Before we jump into today's event, we like to start with a land acknowledgement. We recognize that Medical Herstory is based in Jogjaga, Montreal, and many of our events and operations are located on land which has long served as a site of meeting and exchange amongst Indigenous people, including the Kanien'kehá:ka of the Haudenosaunee Confederacy, Huron-Wendat, Abenaki, and Anishinaabe nations. Medical Herstory recognizes and respects these groups as the traditional stewards of the lands and waters on which many of us are today, and we cannot begin to discuss patient advocacy, barriers to accessing care, or internalized stigma without recognizing the role that colonization, white supremacy, and medical racism play in the social structures which healthcare as an institution is situated in. A few Zoom rules for everybody. So please remain muted if you are not speaking. If comfortable, keep your camera on. Feel free to use the chat to communicate throughout the event if you have questions or comments at any point. And we have active listeners present if at any point throughout the day you find things are getting a bit heavy or you just need someone to talk to, and they'll have active listener present in their name and they'll probably introduce themselves in the chat. Finally, we ask that you be respectful of everyone. We're all coming today from different backgrounds, but we're all here to learn, and I'm really excited to be exchanging ideas with you all. And finally, closed captions are enabled, so you can activate them at any time during the event. And if ever you have any trouble with this, you can just message anyone with Medical Herstory in their name and we'll help you out. So today's schedule, we're starting off with an amazing keynote speaker, which we'll get into shortly. We then have our research panel, which has leading research that's coming out of universities all across the world that we're really excited to be sharing. We will then take a short break before our storytelling session, which will be all about how we can overcome and undo stigma. And finally, we'll wrap up the day and the entire conference with our patient advocacy workshop, which provides practical tips and tricks on navigating healthcare and advocating for yourself. So without further ado, I'll introduce our keynote speaker. Our keynote speaker for today is Gabrielle Jackson, who is an associate editor for Guardian Australia. She's also the author of Pain and Prejudice, which has been published in Australia, New Zealand, the UK, Ireland, the USA, and Canada, and is being optioned for a documentary filmed. So we're really excited to be sharing Jackson's work, which is also influenced by her lived experience with endometriosis and adenomyosis. And we're going to start the day off before I get into Gabrielle Jackson with this amazing quote here, which just says, "We can smash the stigma. For too long, it's been taboo to talk about periods, pain in vulvas and vaginas, and painful sex. We must start talking openly about these things so we have an understanding of the boundaries of normal." So with that, I'm going to stop screen sharing. And because Gabrielle Jackson is in Australia, she kindly sent in a video for us today, which I'll play now.
Almost everything we know about human health comes from the study of men and male animals, even male cell lines. For centuries, medicine has studied men and assumed it applied to women and other people with a uterus too. Assumed, but they didn't know, and they still largely don't. I want to talk to you today about what medicine knows and doesn't know about female biology, what the consequences of that knowledge gap are for women and gender diverse people, and what we can do about it. I'll first address what medicine doesn't know, and then I'll walk you through what medicine has historically thought it knew, why this matters, and what we can do about it. And because there must always be hope, I'll address the great irony of long COVID and its potential to change things for the better. First, what medicine doesn't know about people with a uterus. We literally know less about every aspect of female biology compared to male biology. These are the words of Dr. Janine Austin Clayton, the director of the Office of Research on Women's Health at the US National Institutes of Health. Why is this? Because medicine has traditionally not studied women or female animals, as I just said. It wasn't until 1993 that women were included in clinical trials, and it only occurred then because of the hard-fought campaign led by women and their allies. Until then, drugs were studied in men, then sold to women and gender-diverse people on the public market. Of the 10 prescription drugs taken off the market by the US drug regulator between 1997 and 2000 due to severe adverse effects, 8 caused greater health risks in women. A 2018 study found this was a result of serious male biases in basic, preclinical, and clinical research. So why? Why is it that medicine has not traditionally studied women or female animals? 2 excuses come up. The first is the more prevalent, and it applies to both preclinical, that's the study of animals, and clinical, that's the study of humans, studies. And it's that hormonal cycles in people with a uterus or estrous cycles in female rodents may introduce too much variability into results. And therefore it's just like too expensive to include women, other people with a uterus, and even female animals. Leslie Lawrence and Beth Winehouse summed up this faulty reasoning perfectly in their 1994 book, Outrageous Practices. They wrote, "It defies logic for researchers to acknowledge gender difference by claiming women's hormones can affect study results, for instance, by affecting drug metabolism, but then to ignore these differences, study only men, and extrapolate the results to women." By the way, all human bodies, including cisgender men's, experience hormonal fluctuations. The second reason given is that the trial may affect a woman's ability to bear children. Again, this is a claim that doesn't stack up under scientific scrutiny and suffers from the same lack of logic as the previous excuse. Let me explain. This claim came up after the thalidomide tragedy. This was a drug prescribed to pregnant people around the world, mainly in Germany, the UK and Australia, but others including the US too. It was prescribed for morning sickness. It resulted in 10,000 children being born with severe birth defects. It was after this that women of childbearing age were excluded from clinical trials. However, this drug was not tested on women or any pregnant person before being sold to them. It was not even tested on pregnant animals. This immense human tragedy was not caused by testing a drug on women and hurting the participants. It was a tragedy caused by a failure to adequately test the drug at all and then sell it on the mass market. After this tragedy had taken place, the drug was tested on pregnant animals, and guess what? It was shown to have fetal toxicity. So if this drug had undergone any sort of rigorous testing on animals, it would have found the dangers and not proceeded to human trials. It would not have been sold on the mass market. The knowledge gap created in the 30 years of female exclusion because of this misplaced logic is untold. In her book, Doing Harm, Maya Dusenbury summarised some of the more ludicrous clinical trials that have taken place while excluding women. Some of my favourite examples include a study that looked at whether estrogen could prevent heart disease that only enrolled men. And guess how many women another trial enrolled that considered whether obesity affected breast cancer and uterine cancer? 0. Today, women still make up only 41% of people in clinical trials, even in illnesses where they are primarily affected. I haven't been able to find any really reliable data on how many gender diverse people are included in clinical trials today, but I do believe that work is being done. In animal studies, the picture is even more depressing. In the time since women have been included in clinical studies in 1993, the number of female animals being studied has decreased. A 2009 study found male bias in 8 of 10 fields of biological research. The authors found, and I quote, "Underrepresentation of females in animal modes of disease is commonplace, and our understanding of female biology is compromised by these deficiencies." They also found that the idea that female animals were more variable than male, are too troublesome for inclusion to be without foundation. In 2016, recognising this problem of male bias in preclinical research, the US National Institutes of Health, which is the world's largest medical research funding body, mandated all research should include female animals and analyse results for sex differences. A 2020 follow-up study on sex bias in biomedical research to that 2009 study I just mentioned found that while there was an increase in inclusion of female animals in studies, researchers were still not analysing results for sex differences. So the gap in knowledge still exists. What has medicine traditionally claimed to know about people with a uterus? For a long time in medicine, it was assumed that women were just men with a womb. Woman's difference has always marked her as inferior. The uterus, the most obvious mark of difference, was once considered to be the source of all disease. Then, in the 17th century, the source of women's illness shifted from the uterus to her weak nervous system before shifting back to the reproductive system, this time to the ovaries and clitoris. After the discovery of sex hormones in the early 20th century, it shifted again, this time to her raging hormones. Through all these shifts in blame, society's distrust of women remained constant. And so when they presented with complaints that seemed unique to women, the womb was just assumed to be the culprit. Then the nervous system, then her ovaries, sometimes her clitoris, and then her hormonal cycles. All of these functions revolved around her ability to procreate. Because she had a womb, she should use her womb, the assumptions went. Any cluster of symptoms that women seemed to present with that men didn't came to be blamed on a disease called hysteria, a word that literally comes from the Greek for uterus. Theories that symptoms were caused by a woman not fulfilling her role as a good wife and mother prevailed in medicine for centuries and linger today. Multiple sclerosis, migraine, lupus, endometriosis were all at one time written off as hysteria and causes assigned to the individual. A woman could be told that her illness was caused by too much sex, not enough sex, too much masturbation, using her brain too much, having a type A personality, being a career woman, delaying pregnancy, being too anxious about her health, working too hard, being stressed, or being overweight. Heinous crimes were committed against women in the name of curing hysteria. Clitorises were cut off, ovaries removed without anaesthesia, extreme forms of bed rest and talking therapy were prescribed. Leeches have been attached to cervix and vulvas. Nice-smelling herbs have been placed at the vulva, while foul-smelling herbs have been placed at the nose and mouth to coax the womb back into place. If you can't tell which of these examples is from the modern world and which from the ancient, that's on purpose. Because in spite of radical advances in modern medicine, the myth that women can't control their bodies or emotions and that this brings on debilitating illnesses persists in doctors' rooms around the world today. So much of what medicine purports to know about women's health comes from assumptions, theories based in prejudice about women's place in the world, and even old wives' tales. So what are the consequences? Well, they're huge. I put the consequences into two main categories. The first category I call misdiagnosis, late diagnosis, and death. The second category I call diseases formerly known as hysteria. Let's talk about misdiagnosis, late diagnosis, and death first. In 1990, the Office of Research on Women's Health was formed in the US in response to a campaign to include more women in clinical trials. The office's first agenda-setting paper in 1991 noted a pervasive sense in the research community that many of the health issues of women are of secondary importance, especially those that occur solely in women and those that occur in men and women, but have already been studied chiefly in men. Let me translate this for you. It's bureaucratic jargon that basically means diseases that mainly affect people with a uterus are boring and not that important. And we don't want to study how diseases work in women where we already have a lot of knowledge from studying men. Guess what the result of this gender bias is? Women and other people with a uterus are diagnosed later than men in more than 700 diseases. Women wait longer for pain medication than men. They are more likely to have their physical symptoms ascribed to mental health issues. They are more likely to have their heart disease misdiagnosed, become disabled after a stroke, suffer from illnesses ignored or denied by the medical profession, and they also wait longer to be diagnosed for cancer. Let's look at heart disease. Heart disease is the leading cause of death among women globally. It's traditionally been thought of as a men's disease though, and this has led to deadly consequences for women. In 2004, just for an example, 7.4 million women over the age of 60 died of cardiovascular disease. How many men died of this men's disease? 6.3 million men. Almost everything known about heart disease and its treatments has been learnt from studying men. So doctors have been trained to recognise the signs and symptoms of heart attacks, cardiovascular conditions and strokes in men. But heart disease can work differently in women to men. It can even work differently among men. I spoke to the cardiothoracic surgeon Dr. Nikki Stamp about this problem. She told me there's this difference in biology between a man's heart attack and a woman's heart attack. What this means is that the symptoms can be different. Our diagnostic tests may not be geared to pick up the problem, and also our treatments probably don't work as well for that different biology. When sufferers present with so-called atypical symptoms, they're often misdiagnosed or sent home with anxiety or some other problem. A 2018 study published in the Medical Journal of Australia found that women were half as likely to be treated properly for a heart attack as men, and twice as likely to die within 6 months. Now that only looked at a very specific and quite deadly form of a heart attack, and it was done in Australia's leading hospitals. Let me remind you, that was only in 2018. A 2017 study in the US found that 22% of primary care physicians and 42% of cardiologists said they felt extremely well prepared to assess women's cardiovascular risk. Let that sink in. Fewer than half of heart specialists feel very well prepared to assess whether a woman, half the population, is at risk of some kind of heart disease. And that's not all. Just last month, a major new study of 400,000 Europeans found that nearly 12,000 women in the UK have missed out on appropriate care for their heart attack over the past 2 decades, and some have died as a result. Why? Because the current scoring system for heart attack risk, which is applied to both sexes, was developed only using data from men. The research by experts at Imperial College London and the University of Zurich found that 5% of women who suffered a heart attack were wrongly classified as not at high risk of death. Some will have missed out on life-saving emergency treatment as a result, such as surgery to restore blood flow to the heart or clot-dissolving drugs. As I said before, some men also experience these atypical symptoms. So guess what? Recognizing the whole range of symptoms of heart disease benefits all humans. Who could have guessed? If even doctors aren't recognizing women's risk of heart disease, it goes without saying that many women and gender diverse people don't know they're at risk either. Many delay seeking treatment because they think they can't be affected. They don't recognize there are symptoms as heart disease. So people who have had preeclampsia, gestational diabetes, or high blood pressure during pregnancy are at particular risk for cardiovascular disease and stroke. Yet many are not aware of this, and they're not being warned by their healthcare professionals. If they can get it so wrong on such a big killer, imagine what's happening in diseases that have not had the kind of research dedicated as heart disease. This is the category I call diseases formerly known as hysteria. These are diseases that predominantly affect people with a uterus, and these are the illnesses that have not received a lot of research funding or attention. Many have been written off as hysteria for centuries, and some still are. Let's first talk about autoimmune conditions such as rheumatoid arthritis, lupus, and multiple sclerosis. About 78% of people with autoimmune conditions are women or people assigned female at birth. They occur when our immune system, which defends the body against bacteria, viruses, and other germs, turns on itself and starts to attack its own healthy cells, tissues, or organs. Autoimmune disease is a leading cause of death and disability in women and other people with a uterus globally. Why? Well, science doesn't know for sure, but we do know that the male and female immune systems work slightly differently. Female immune systems tend to be more flexible, they produce more antibodies, and are just better at fighting infections. This is evident from the earliest days of life, with premature babies assigned female surviving better than males. The upside is women tend to survive infections better than men. The downside is that they often don't return to their normal levels of health. They survive, but they're sicker. This greater flexibility of the immune system means it can also turn on itself, and this is probably the reason women are more prone to autoimmune diseases. There are about 100 different autoimmune diseases and no cure for any of them. While treatments have greatly improved in the past 2 decades, there is still so much work to be done. People with a uterus around the world face lengthy delays in diagnosis for autoimmune conditions. Almost half the women eventually diagnosed with one of these diseases will have been told by their doctors that they're hypochondriacs or too concerned with their health at some point on their journey to diagnosis. Multiple sclerosis was once called hysterical paralysis, and even though it was way more prevalent in women, men were more likely to be diagnosed with a serious neurological condition. It was even considered to be more common in men because, as I just said, men, when they presented with symptoms, were diagnosed with an organic condition. When women presented with those same symptoms, they were kind of written off or diagnosed with hysteria or some other kind of mental illness. It was only by accident of technological advancement that MRIs were able to pick up the physical proof of MS, that medicine realised it was 3 to 4 times more common in women. Chronic pain is another condition that predominantly affects people with a uterus. About 70% of chronic pain patients are women, but 80% of pain studies have been conducted on men or male mice. As the researcher Mark Hutchinson said to me, this is just useless. He's been one of the researchers to discover that chronic pain acts differently in female versus male biology. There is nothing that tests on human men and male animals can tell us about the experience of chronic pain in people with a uterus. And yet that's where most of the research to this day has gone. What's been thrown out that could work? We just don't know. The disparity in pain in men and women lasts throughout their reproductive lives. As children, boys and girls experience roughly the same levels of pain. But once girls reach adolescence, the number of them experiencing pain that lasts more than 3 months, that's what we call chronic pain, is leaps and bounds ahead of the boys. Almost all the major chronic pain conditions affect more women than men, including endometriosis and vulvodynia, obviously, but also rheumatoid arthritis, migraines, ME, chronic fatigue syndrome, and fibromyalgia. While chronic pain affects the same number of people as cancer, heart disease, and diabetes combined, figures from the US show it receives 95% less research funding. The historic report Relieving Pain in America found that 4 in 10 adults live with chronic pain disorders, and they recognised a cluster of pain conditions that frequently co-occur solely or predominantly in women. They were later given a name by the US Congress, and they were called chronic overlapping pain conditions. These 10 conditions are endometriosis, vulvodynia, fibromyalgia, chronic fatigue syndrome, which is also known as myalgic encephalomyelitis, interstitial cystitis or painful bladder syndrome, temporomandibular joint disorders, that's jaw pain, irritable bowel syndrome, chronic tension time headache, chronic migraine, and chronic low back pain. All of these conditions are beset by misdiagnosis, lack of coordinated medical care, and a sparsity of safe and effective treatment options. But doctors are not taught about this gender bias in their training. They are not taught that there will be women and gender diverse people sitting in their waiting rooms with generalised symptoms of pain, fatigue, brain fog, who they can't help because medicine has not bothered to study them. They are trained to see them as anxious and difficult and to blame for their own poor health. All of this leads to a poorer quality of life. Often when I'm complained about gender bias in medicine, men will reply that women live longer and so therefore men's health is the real problem. Women may live longer, and I'll get to that in a minute, but men now have overtaken women in active, healthy years. That is, if you count the number of years you live in a healthy way and an active way and you can go about your life normally, men have overtaken women in the last decade. And a recent study by academics in Denmark has even called into question whether women do actually outlive men after all. According to a report published in The Guardian, the study, which was published in the BMJ Open Journal, examined data on the lifespan of men and women across 199 countries for 200 years. It concluded that men have a high probability of outliving women, especially those who are married or have a degree. The authors said, males who are married or have a university degree tend to outlive females who are unmarried or do not have a high school diploma. The analysis also found that in developed countries, the probability of men outliving women fell until the 1970s, after which it gradually increased in all populations. But let's not despair. There is hope on the horizon. The greatest scandal of long COVID is that it was entirely predictable and we should have been prepared. We know more men die from infectious diseases and that women survive but do not fully recover. An old medical adage goes, men die quicker, women are sicker. Anyone who has studied ME or CFS knows that a portion of people, mostly women, have long-lasting post-viral illnesses that affect their ability to fully function. We know it happens after glandular fever, it happened after SARS, it can happen after the flu. But medicine has been so dismissive of ME/CFS, it has received negligible funding and a whole lot of stigma. If medicine had bothered to listen to people with this disease, they might have been prepared for long COVID. But some people were. They were patients with ME/CFS and the doctors and researchers who have devoted their lives to studying it. They reached out online to long COVID patients in the earliest days of the pandemic. Together, they lobbied. The sheer number of people suffering from long COVID can no longer be ignored. The effect on the economy and the health system cannot be ignored. More research funding than has ever been dedicated to ME/CFS has now been promised to long COVID research. And because most patients are women, they'll be studying immune system effects in both sexes. And they'll be looking at how the immune system interacts with both infectious and non-communicable diseases. This research may unlock some of the mysteries surrounding many chronic pain and other chronic illnesses that have long been neglected in medical science. So what can we do about all of this? We can do some things. First, we can smash the stigma. For too long, it's been taboo to talk about periods, pain involving vulvas and vaginas, and painful or unenjoyable sex. We must start to talk openly about these things so we have an understanding of the boundaries of normal. It is normal to have pain with your period. It's not normal for that pain to be so severe that it interferes with your ability to do the things you want to do month after month after month. It is common for women to have pain during sex, but it's not normal and it doesn't have to be that way. One study found that almost half the delay in diagnosis for endometriosis was down to a failure to report symptoms. If you don't know it's not normal, why report it? Please talk to people about these issues, and not just among women and gender diverse people. We need to make these conversations common in our society. We can get organised. We need a global campaign for gender justice in health. Only well-organised and sustained campaigns can make a difference in changing medicine. But we have seen it happen often enough to know it works. Breast cancer patients were once told it was a career women's disease, or that they got breast cancer because they delayed childbirth. But women and their allies changed this by organising, raising a lot of money, and then demanding a say in the kind of research that money funded. This is important because not all research is created equal. Endometriosis, for example, has received a boost in funding since awareness around it has increased in the past decade. But not all of it is that helpful. One study I reported on at The Guardian rated the attractiveness of women compared to the severity of their disease. I'm not joking. The study was titled Attractiveness of Women with Rectovaginal Endometriosis, a case control study. It was first published in 2013. It's now been retracted, but it was defended by the authors and the journal for a long time, and some still are defending it. The study concluded women with rectovaginal endometriosis were judged to be more attractive than those in the two control groups. Moreover, they had a leaner silhouette, larger breasts, and an earlier kotarchy. Kotarchy is the age at first sexual intercourse. The women taking part in the study had not given their consent to be judged for their attractiveness and didn't know it was happening as part of their medical consultations. The authors asked the women about their sexual history. They measured their body mass index, waist to hip ratio, and breast to underbreast ratio. Only Caucasian, their word, women were selected to be included in the study. While some bodily characteristics can be associated with certain diseases and symptoms and should be studied, this was not what this study measured. It subjectively rated women's attractiveness without their consent. This is a very good example of why patients must have a say in the kind of research that's commissioned. There was a case in the 90s where the US Congress devoted some research to ME/CFS, and it was just misused, and other things were studied instead because the researchers didn't think it was worthwhile. When they did do studies, they studied things like the types of personality of people who get ME/CFS. We need to demand more resources for research that looks at female biology, both in animals and humans. We need to ensure gender diverse people are included in this research and results are analysed for difference. Finally, we can all make sure the information we share online is credible. I've seen many well-meaning people spreading misinformation or misinterpreted information online. We have to listen to the experts. While it's true medicine has failed us in some ways, it's not true that all doctors and nurses are bad people that we can't trust. We have to believe in science. There are many experts on our side. We have to listen to them and work with them to spread factual information that is backed by evidence. And we have to call out when not enough evidence exists. Medical science is not perfect, but it is the only hope we've got. Thank you so much for listening. I hope you enjoy the rest of the conference.
Amazing. So I hope you all enjoyed that speech. I know some of you in the chat have been expressing how much this talk meant to you. And now that we've heard a bit about the past relating to gender health and equity and the present, we're also going to be talking about the future a bit more with our student research panel. So kind of as I will hand to
our research panel today. I'm so glad for those of you who are just joining us. Welcome to our Feminist Health Conference. My name is Kainaz, and I'm the Director of Operations here at Medical Herstory. So we'll just dive right in. First, I'd like to begin with the land acknowledgement. So Medical Herstory is based in Tjojage or Montreal. Many of our events and operations are located on land which has long served as a site of meeting and exchange amongst Indigenous peoples, including the Kanikanaka of the Haudenosaunee Confederacy, Bruin-Wendat, Abenaki, and Anishinaabe nations. Medical Herstory recognizes and respects today. We cannot begin to discuss patient advocacy, barriers to access and care, or internalized stigma without recognizing the role that colonization, white supremacy, and medical racism play in the social structures which healthcare as an institution is situated in. All right, and again, for those of us joining just now, Medical Herstory is an award-winning youth-led international nonprofit advancing and advocating for gender health equity. And I see that our panelists are starting to turn their cameras on, so we will move things along. Before we jump into introductions, I do just want to go over some Zoom rules yet again. So please do remain muted if you aren't currently speaking. If comfortable, it would be delightful if you all turned your cameras on, especially since our researchers are here with their cameras on. Please feel free to use the chat to ask questions or leave comments. And we do have active listeners present. They have the title active listener in their Zoom name. And as always, please do be respectful to everyone, and note that closed captions are enabled, so you can just activate them at any time during the event. Sorry, okay. So with that, just a quick note. So our Q&A will take place after all of our speeches. We'll have a 15-minute question and answer period. You can use this QR code now or enter this code to send questions in during the speeches, however, through our Menti. And I believe someone will drop this code in the chat as well. So feel free, I'll just pause for like a couple seconds, scan the QR code, enter the Menti code. Okay, and otherwise, during our question and answer period, you're welcome to put your hand up, turn your mic on, or also just send a message in the Zoom chat. All right, I believe with that, we are ready for our research talk. So first, I'd just like to briefly introduce all of our fabulous speakers today. So if you all could just give a little wave when I read your name. So first up, we have Julia, who's going to be acknowledging and communicating gender bias in medicine through visual artwork. And Julia will be followed by Victoria, whose focus is women's experiences of chronic pelvic pain and self-help in late 20th century Britain, followed by our very own Ellen Anderson, who's looking at determinants of self-advocacy of female patients at the primary care setting in the UK. And then we have Maya, who's going to be presenting a feminist analysis of pelvic exam violence, followed by Marlene. Now, Marlene is actually going to be coming in through video because Marlene is also based in Australia, where it is currently 2 a.m. And Marlene's focus is gender sensitivity among health students. And then finally, wrapping us up is going to be Chloe, who will be presenting on the recognition or lack thereof of side effects of hormonal contraceptive use in the UK. So with that, I am delighted to formally introduce Julia. So Julia's pronouns are she, her, and she is a current second-year medical student at the Washington State University. She graduated from Stanford University in 2020, the Bachelor of Arts in Human Biology and a Bachelor of Arts in Studio Art. And her work integrates medicine and the arts to address issues of historic and ongoing gender bias in healthcare. Julia, the floor is yours.
Thank you so much. So like she said, my name is Julia Todderud. I am a second-year medical student at the Elson S. Floyd College of Medicine in Washington State. And I'm speaking today on my work with utilizing visual artwork to communicate gender bias in medicine. Thank you. I had three primary goals of my project. First, I hope to use art as a tool to communicate issues in healthcare. Often I feel that standard research practices can give us the data and the facts, but to make change, we have to find other ways to facilitate these discussions. And I felt I could best make these complex issues more accessible through visual artwork. I also hope to integrate humanities and medicine, as so much benefit can be found in the crossover, and explore concepts related to gender bias in medicine with a historical and contemporary lens. So here I just wanted to emphasize that for each art piece, it is based in literature review and has been developed really intentionally, with each having a style, characteristics, and medium meant to elevate the concepts that it is meant to convey. And next slide. Thank you. So this is an overview of each of the pieces that I'll be focusing on today. We have 3: hysteria, 5.5, and eponym, and below each are a few descriptors that kind of reference those characteristics that are intentional aspects to build to the theme of the piece. And with that, we'll move into the first piece. So here is This painting is 3 feet by 4 feet, and it is titled Hysteria. And on the next slide, you will see a few detail images of this piece as well, as sometimes the colors can get affected by images and so on. And you can continue to the next slide. Thank you. So the subject matter of this piece is a histological sample of a menstruating uterus. In creating this work, I was hoping to unpack some of the history regarding the medical diagnosis, hysteria, that was actually discussed by our keynote speaker just a moment ago. So again, this term was used as a blanket mental health diagnosis for women experiencing any variety of struggles, from depression to endometriosis to sexual promiscuity. And for this diagnosis with inherently sexist undertones, the theorized treatment was marriage with the perception that semen would decrease the symptoms. The phrase hysteria persists as a term to describe insanity or a state of being over-emotional, with pervasive biased usage as well. With the portrayal of a uterus, I hoped to in some way reclaim this wandering uterus and give it the respect we serve any other organ in the body, especially given how unique its dynamic nature is with the ever-changing histology throughout the menstrual cycle. An additional intent in creating this piece was to comment on the taboo associated with menstruation. Despite it being an incredibly normal physical process, it is avoided in discussion. I remember in one of the early classes of medical school, several of my male peers said they would not discuss menstruation with a young female patient. This seems to not only demonstrate that stigma, but also speak to a decreased quality of care for female patients as a result of their sex. So on to the next slide is the next piece, and this one is entitled 5.5. And again, the next slide will show some detail shots. So medical technology and supplies have not been designed with female bodies in mind. Often, female health care workers have to find ways to adapt technology, whether using step stools to reach operating tables, needing 2 hands for certain tools, or finding ways to adapt scrubs for female bodies in general, and even more so for women that wear hijabs or other articles. This art piece focuses on gloves. So both procedural and surgical gloves are designed with a standard using male hands. The average size of surgical gloves for women is 6, with the second most common being 5.5. For most companies that produce surgical gloves, 5.5 is the absolute minimum size that they make. I wear size 5.5 surgical gloves, and I cannot count the number of times a clinic or an OR has not had my size of gloves available, or even the physician present will tease the size of my hands because those gloves are not available. This issue does not end with just poorly fitting equipment. Worse patient outcomes are directly related to the accessibility for female bodies, as the difficulty to use or wear these products can cause injury to both the patient and the practicing healthcare worker. The use of a traditional style in this piece is meant to connect with the historical roots behind the development of medical equipment, and I utilize contrast very intentionally with the complementary colors of blue and orange, the difference in detail of the hands and background, and the sharpness of the shadows to create a slightly dissonant feel that shows that these do not fit into existing schemas. It is intended to highlight the existing problems with this aspect of our field while also indicating the need to improve accessibility. And moving into the final piece, before that, this is just a transition showing how an image like this is built up over time. Thank you. So this final piece is called eponym. So the word eponym describes those things that have been named after people. And the next slide will show some image shots as well. Much of medicine and science has been named after people. From the beginning of medical school, we studied the minutiae of anatomy, and with every successive anatomical eponym, I became a bit more frustrated because any part of anatomy named after a person has been named after a man. And to my disappointment, this also includes primary and secondary sex characteristics most associated with female bodies. Fallopian tubes, pouch of Douglas, Bartholin's glands, lactation ducts in the breast, and more are all branded with the names of male physicians. This feels especially inappropriate, giving an ownership of female bodies to men that made these decisions when women weren't even allowed in the academic spaces where these professional discussions were occurring. With the central piece of this work pictured here, I hope to represent this concept. Each of these tags is one of the names of the men that created anatomical eponyms. The red tags that you see are those that are associated with female anatomy. And on the next slide, it will show the two pieces that go on either side of the central piece, and they feature the names of women who have left their mark on medicine. Originally, this piece was just that center one, but I started to realize that that would only be raising up those voices of the men that have their names in that space. And I wanted to make sure that we were also acknowledging the women in this field. So though no women have anatomy eponyms, their contributions to research, clinical care, and medical progress deserve to be acknowledged. I absolutely loved looking up all of these women and reading their stories, especially for the conditions that I had not been aware were named after women physicians. Most notably, I recognize Potter syndrome, Apgar scores, the Cori cycle, Epstein-Barr virus, and HeLa cells and their associated ethics violations. With this piece, I hoped to amplify the voices of those medical heroes and leaders in our field. So I hope that this kind of touches on that aspect of finding new ways to communicate and connect these very complex issues in a way that's accessible in a different way and finds new ways to represent these subject matters. I am hoping to find more opportunities to connect this work and extend it by growing this series of artwork, or also finding new ways to connect it with community in our healthcare community and for women in medicine as well. And reminder, if there's any questions, like feel free to post them in Menti, or my contact information is posted in the chat as well. And thank you so much to Medical Herstory for allowing me to speak on this today.
Thank you, Julia, so much for presenting your absolutely stunning, moving, and powerful artwork. I do have to say, as a former anatomy and cell biology student, the histology piece, when I first saw it, made me gasp out loud. All of your work is so amazing. So we're very glad you were able to be here with us today and present this as a little precursor to the rest of our research panel. So now we will move on to our next speaker. And yes, our wonderful panelists' social or contact details will be shared in the chat as they present their research. So feel free to bookmark that, follow them on social, and otherwise, like I said, we will have like a question and answer period at the end of everyone's speeches. So moving on to Victoria. So Victoria, as I said, will be presenting on women's experiences of chronic pelvic pain and self-help in late 20th century Britain. Victoria recently graduated from her MPhil program in modern British history from the University of Cambridge, where she was supervised by Dr. Lucy Delap. Her graduate research is focused on the experiences of women with chronic pelvic pain and endometriosis in late 20th century Britain, alongside the work of the National Endometriosis Society in Britain, now called Endometriosis UK. Victoria was drawn to the subject by the lack of historical research into gendered constructions of pain and a personal interest in the impact of medical misogyny on the treatment of endometriosis. Although she is currently taking some time out of academia to pursue a career in the charity sector, Victoria is very interested in continuing her studies at the PhD level. Victoria.
Hi, as Kana says, I'm Victoria, and I looked at women's experiences of chronic pelvic pain and self-help in late 20th century Britain. And to streamline my research, I chose to scrutinise how British women with endometriosis were treated in the late 20th century, and how the gendering of endometriosis as a female disease and the normalisation of pain in the women's life cycle led to a lack of endometriosis awareness and significantly impacted the treatment of chronic pelvic pain. So if we could go to the next slide, please. So today, Endometriosis UK defines endometriosis as a condition where cells similar to the ones in the lining of the womb are found elsewhere in the body. And these cells react every month in the same way as those in the womb, building up, breaking down, and bleeding. There's no way for this blood to escape, which is thought to cause the pain associated with the condition. The tissue is found in the pelvic cavity and sometimes in the diaphragm and in the lungs. Pain can be cyclical, constant, or random. Endometriosis causes fatigue, depression, and infertility, and it's a very under-researched condition, resulting from medical misogyny that deems the female reproductive system as too complex, and from this ancient correlation of chronic pelvic pain with hysteria or neurasthenia. I would just like to point out that it is a condition that affects anybody with a uterus, and organisations like Endometriosis UK are now seeking to make the campaigning much more inclusive, to include trans men who face gender dysphoria and institutional bias in their access to healthcare. Unfortunately, these experiences are not really reflected in historical archives, and I was unable to find a trans story through my oral history project. In my thesis, I also look at fibroids and fibroids activism to locate specific experiences of Black British women, but I don't really have time to talk about that today. So my integral framework was through a history of pain. I want to do a history of pain that's centered around gender. There are several histories of pain done by these wonderful historians, Elaine Scarry, who is a cultural anthropologist, and they've all looked at very different ways of understanding pain through history. But there are a few studies that look at how gender impacts pain perception in the late 20th century. So how can we do histories of pain when we have so few sources pertaining to the late 20th century? I decided to look at the Wellcome Collection archives, and I also did my own oral history project to understand how women perceived and understood their pain and how their social contacts perceived them. The more they use metaphor, the more their doctors shut down. This is quite a general statement, but this was the overall experience that I found with the women I interviewed. And two of the women I spoke to who were diagnosed during investigations into infertility. So through defining pain caused by endometriosis through this reproductive framework, and through applying gender constructions to this pain, medical practitioners were normalizing women being in extreme levels of pain and often only acted when they were trying to preserve fertility. This led me on to looking at how endometriosis pain was normalized and associated with the female body through its heavy association with menstruation. Now, menstruation in history is another hard one to find in historical sources. I managed to find some great responses to a 1996 mass observation directive on menstruation, which was sent to both men and women. And during my research, it became very clear that many women were experiencing symptoms from puberty and from when they started their periods. Now, throughout the 20th century and before, cultures of silencing surrounding menstruation and hundreds of mass observers noted they were never told what was happening to them. Many who started in the 1940s and 50s believed that they were dying, and I found responses from women who had gone to school in the 1980s, describing their periods as the curse, and this is how it had been described at school. Now, in Britain at the time, women's liberation did seek to challenge this characterization of periods as something inherently bad and as the female body as, being diseased. But there's a paradox here. I found one mass observer who said that although she identified as a feminist, her periods were really painful and she didn't want to celebrate them. So whilst we shouldn't pathologize periods at all, by any means, we do need to recognize that endometriosis does present as very painful periods. And we need to ensure that this pain isn't normalized. Young girls in Britain were starting to learn a lot more about periods and their bodies, whether that be through their school or their parents, as noted in a 1984 Spare Rib article. And even though there seemed to be more discourse on periods, this discourse was controlled by the history of periods as being very taboo, being hidden, being discreet, and in many cases, painful periods were normal. There's a study by V.R. Tyndall, who's a gynecologist in the 1970s, saying that young girls who presented with severe period pain were simply being overdramatic. For many young girls, this was how endometriosis started for them. And I'm going to let some of their narratives speak for themselves. An 18-year-old wrote into the National Endometriosis Society in 1995 saying, "I've had pain since 14. I've been constantly fobbed off by my doctors. They thought I was making the whole thing up to get out of going to school." So not only does this show us the social nature of pain and how people share pain and how responders can deny this pain, it shows us that severe period pain was just seen as normal. And now there were groups who were trying to challenge this. And I wanted to look through this framework of the women's health movement in the 1970s and the 1980s, or a vernacular feminist sort of health movement that was kind of based on feminism. And I found this through the National Endometriosis Society. So if you had the next slide, please. So the National Endometriosis Society was part of this network of women's health organisations founded on somewhat feminist principles. And in doing this, I wanted to look at how self-help can be used by women in pain. And I wanted to challenge a neoliberal definition of self-help, which was self-help for self-improvement. In my study, I saw it as something that was actually quite radical. So the National Endometriosis Society was founded in 1981 by Ayla Irving, and she put an ad in the Guardian personal pages, which is on the slide, reading, "Endometriosis, do you suffer? Let's unite to help each other." So the tagline really underlies the central ethos of what would become the NES, National Endometriosis Society, offering support and self-help strategies for women with endometriosis. And for the first 9 years of the group's existence, meetings were in her own home, and they achieved charity status in 1982. Irving organised the national newsletter herself, which helped women across the country form their own local groups so they didn't have to travel all the way to London to partake in the London Self-Help Group. And in 1990, they moved to a Brixton office with the support of the Department of Health grant, I hope I haven't frozen, and beforehand was supported by the King's Fund. So by the 2000s, they had completely transformed into Endometriosis UK, but self-help was still right at the heart of their charity. The idea was that women could share their pain with others and they could end their isolation through doing so. So even though we see the 1980s through feminist history as a time when the women's liberation movement was being torn apart by internal differences, we can see that the NES used the infrastructure of the feminist movement to spread awareness of their society. They reached out to journalists like Jill Rakusen, and they published a lot through feminist periodicals like Spare Rib. This is part of recognising that women's health is much more than reproductive rights within a history of feminism. Reproductive rights are obviously very, very important, but through the lag in diagnosis and having their pain discounted, the women I've spoken about today were fighting for their bodily autonomy much more generally. Of course, NES activism didn't include all women at the time, but they are hoping to be much more inclusive now. So my very broad conclusions from this talk is that constructions of menstruation within British society impacted how the medical profession understood women presenting with chronic pelvic pain, putting them down to bad periods. We need to take an intersectional approach to this history, and I haven't really managed to talk about that much in this short talk, but we do need to look at race, class, disability and age within, whilst we look at gender as well, because these are all factors that limit the sharing of pain, and they shut down lines of communication because of cultural understandings of womanhood and women's bodies in the context of the late 20th century. National charities like Endometriosis UK have raised the profile of endometriosis, and many more people now know about the condition than they did in 1981. But the diagnostic rate in the UK has not changed since 1994. It's still 7 years. So by taking a feminist approach to this history and establishing the NES through vernacular feminism, which is they weren't inherently, they're not shouting out, we are a feminist organization, they're more based on feminist principles. We can look at how they're structuring through a network of self-help groups, so through the national newsletter, forged a discursive space for women with endometriosis to reach out to one another and to share their experiences of pain. And theories of pain and the relation to femininity and womanhood were challenged through late 20th century women's health activism, which should be understood as much more than championing reproductive rights. So thank you very much for listening, and thank you to Medical Herstory for putting together this wonderful conference and panel.
No, thank you, Victoria, for condensing such comprehensive and meaningful research into the short time that we were allocated today. I think all of us here who are familiar with endometriosis or patient advocacy in today's kind of environment can appreciate how much hasn't changed and yet how much progress organizations like the ones you're involved with have been making. So thank you so much. With that, we will move on to our next speaker, our very own Ellen Anderson, who is looking at determinants of self-advocacy of female patients in a primary care setting in the UK. So Ellen recently completed a master's in global health and management at the University of Aberdeen and holds a master's in social anthropology from the University of St. Andrews. Ellen has always been interested in healthcare, but knew that studying medicine or nursing wasn't for her, so she wasn't sure how she could get involved. But having found Medical Herstory, Ellen has been volunteering with us for over 1.5 years, and she's now the director of HR and volunteer support. Her passion for healthcare, and in particular women's health, has only grown stronger over time, and she dedicates her time to working towards empowering everyone to advocate for the highest possible standard of healthcare. I'm delighted to present Ellen.
Thank you very much. Hi, everyone. As you saw, my name is Ellen. I'll be presenting a study titled Identifying Determinants of Self-Advocacy of Female Patients at the Primary Care Setting in the UK. The study was undertaken as part of my Master's in Global Health and Management at the University of Aberdeen with the supervision of Dr. Mintu Nath. When an individual enters a medical setting as a patient, they are there to seek the expertise of a professional. At the primary care level, patients must navigate medical advice and treatment plans with their own knowledge and understanding, with any supplemental information from doctors. And this is where the practice of self-advocacy comes in. Self-advocacy is defined as the ability to seek, evaluate, and use information to promote one's own health. This practice is becoming increasingly prevalent within healthcare, and it is documented as an essential skill in chronic disease management. There's limited literature on self-advocacy within the primary care level, particularly for those without chronic illness, so this study seeks to address this. Building upon determinants that are identified in nurse and patient advocacy, the study will focus on the 3 determinant categories of personal, societal, and institutional attributes. The study aims to answer the research question of what determinants act as barriers to the practice of self-advocacy for women at the primary care setting in the UK. As there's limited literature available on self-advocacy at the primary care level, we reviewed methods used in the existing literature surrounding nurse-patient advocacy, as well as studies exploring the self-advocacy skills present in those with chronic illness. We identified their determinants and findings and built upon these to create a quantitative cross-sectional survey. The target population for the survey is women aged 18 or over who've attended a GP appointment either in person, over the phone, or online in the past 12 months in the UK. The survey was distributed on a digital medium, and social media was used as the primary recruitment method, with Medical Herstory sharing the recruitment adverts on their media platforms. The 3 attributes are represented with 5 questions each on a 5-point Likert scale. To supplement this information, there were also 5 questions that covered the demographics of the sample, including age, highest level of education obtained, if the participant follows any social media accounts that promote self-advocacy, if the participant belongs to any patient advocacy groups, and the perceived health status of the participant. Alongside 4 questions that cover consent and eligibility criteria, the survey is made up of 24 questions. The survey was open for 5 weeks and received 355 responses. In order to simplify the findings in this presentation, I'll focus on the 2 demographic characteristics of participants' age and perceived health status, as these had statistically significant evidence of associations for all 3 determinant categories. After initial concern during peer review that recruitment through social media may have resulted in a narrow age demographic being targeted, we were thrilled to see that we had a wide variety of responses, including 6 participants over the age of 76 years. We can also see here that most participants rated their perceived health status as good, followed by very good or excellent, and then poor or fair. All of the answers for the questions on the Likert scale were coded from 0 to 4, meaning that across the 5 questions of a determinant category, a participant could score a maximum of 20. For personal determinants, an increase in scores reflects an increase in participants' perceived confidence in paying attention to their body and their concerns, and in communicating this with their doctor. For societal determinants, an increase in score reflects an increase in the frequency that participants discuss their health with those in their life, and the frequency in which they conduct health into their own concerns. And for institutional determinants, an increase in score reflects an increase in perceived confidence that their doctor listens to and values their concerns, and that their doctor is working collaboratively with them. The findings reveal that as a participant's age increases, so does their score for personal and institutional determinants, which supports existing literature suggesting that with an increase in age comes an increase in confidence when communicating and working with a doctor. We can also see that with this increase in age comes a decrease in the frequency in which participants conduct research into their health. Now, this may actually further prove this theory, suggesting that as older patients place a significant confidence in the knowledge of their doctors, they see no need to conduct their own research. Analysis reveals that as participants' perceived health status increases, so does their score for personal and institutional determinants, so their confidence in communicating and working with their doctor. This may be explained by the absence of the trust gap, a phenomenon where doctors dismiss the concerns of female patients due to lack of knowledge and lack of trust in women self-reporting their concerns. We can draw the conclusion that those with a higher health status have less need to present their concerns to their doctor, and as such may face less dismissal, which in turn influences their confidence in communicating with doctors. And we can also see that there's a decrease in the score for societal determinants. Existing literature suggests that with the decline in health status comes an increase in advocacy skills. So the decreasing score for societal determinants may suggest that as the participants' health rating increases, they see little need to conduct any research. And while there was no statistically significant association between following a social media account that promotes self-advocacy and any of the determinant categories, there was some evidence to suggest that those who follow such media accounts show a higher frequency of independently researching health concerns. The findings of this research have many future implications. We were thrilled to have received such a high participant number in this survey, which suggests that this is a topic that people really do want to talk about and a topic that influences everyone. The findings can be used in future research to determine how doctors can improve their communication with patients and in turn improve patient satisfaction in health settings. And the findings can also be used by organisations such as Medical Herstory, who can use their social media reach to help individuals in their self-advocacy experiences, which will also lead to improved patient experiences. Just the references. So thank you very much for listening, and thank you to Medical Herstory for not only including me in this fantastic research panel, but for also sharing my research recruitment and through supporting me throughout the process. Thank you.
Thank you, Ellen. It is such a joy to work with you and also to have had you on this panel. And this is just a note, since we are on Ellen's slide, that we will be opening recruitment soon. So if anyone's interested, let us know. Keep an eye on our socials. But no, Ellen, that was fascinating research and so important. It's really amazing that you were able to share it with us today. And with that, we will move to our next speaker, who is Maya. And Maya will be presenting a feminist analysis of pelvic exam violence. Maya is a feminist researcher, writer, and advocate. She received her MA in Women's and Gender Studies with distinction from DePaul University in June. Her research areas include a wide range of reproductive justice-related topics, including gynecological violence, consent practices in medical contexts, and midwifery practices. Maya currently lives in Chicago and enjoys spending time by the lake, going to concerts, and trying new restaurants in her free time. And she recently finished her position as a research assistant and is excited for new opportunities. Maya.
Hi, everyone. My name is Maya Parekh, and I'll be presenting my research project, A Feminist Analysis of Pelvic Exam Violence. I completed this research project as part of my MA program, which I just finished in June. To begin, I'd like to clarify the exact issue that I researched, which is the practice of non-consensual pelvic exams performed on unconscious individuals. This typically looks like a patient going in for a procedure, often in a gynecology or obstetric space. And once they are anesthetized, medical students will practice examinations on them for the purposes of education and training without previous consent. This practice is legal in 29 states in the US. I'd also like to add that it's widespread in the UK as well. Although it is completely legal, I label this practice as a form of sexual assault. There are two main components to my research. The first is a discourse analysis where I seek to understand medical attitudes towards the practice. And the second is a legal analysis where I evaluate existing legislation in this area and how effective it is at addressing the issue. The driving frameworks behind my project are a reproductive justice framework by Loretta Ross, an intersectionality framework from Kimberly Crenshaw, as well as Dean Spade's legal critique of legal rights approaches. I chose this issue because I think it's important to research exactly how and why this practice occurs in order to develop a comprehensive solution. I'm also passionate about bodily autonomy and creating safe and accessible healthcare. For my discourse analysis, I focused on these teaching exams and I analyzed the arguments of both proponents and opponents of the practice. I chose about 35 articles from different journals of medicine, nursing, and bioethics, and I selected the most frequent points of tension or controversy between the two sides that I found throughout the literature. Although I went into this project initially expecting to only critique those who were defending the practice, I found myself critiquing both sides of the literature. And this is because I really believe that the reasoning matters in the arguments. Both sides of literature, both those who defended the practice and those who advocated against it, were still upholding harmful and dominant medical paradigms. Neither of them truly challenged power. And I conducted this critique with reproductive justice values in mind, particularly autonomy, the patient's right to information, and patient determination. So I had several findings throughout my discourse analysis. I don't think I'll be able to talk about all of them for the sake of time, but I'm going to select the most important few. The first I'd like to address is the different ethical frameworks operating in this issue. Those who defend the practice advocate for a utilitarian framework, which led them to view patients as teaching tools, created a sense of entitlement towards patients' bodies, and led to a dangerous opinion that harm to one patient can be justified as long as it's in the name of a greater good. In contrast, those opposing the practice advocated for a Kantian framework, which suggests that patient care must follow a decided ethical code. However, I believe that we need to question who gets to create that ethical code. Both sides of this argument continued to uphold doctor perspectives and did not emphasize the importance of incorporating patient needs. Additionally, neither incorporated human rights language, specifically the right to bodily integrity, which is essential in reproductive justice. The next argument that I'd like to address is the concept of standard procedure. Proponents of this practice often cited the routineness, the long-standing history, and the objectivity of the physician as a defense of why this practice should be allowed to continue. In contrast, opponents of this practice would cite association statements, such as those from the American Medical Association and the American College of Gynecologists and Obstetricians, their guidance against this practice as reason enough for why it should be discontinued. However, both of these arguments continue to affirm the all-knowingness of the doctor as the system who should be allowed to define what constitutes harm. There were some opponents who uplifted patient perspectives, citing patient research that most people would want to be asked for consent, which I do believe upends the dominant power dynamic we have currently. The next point I'd like to address is the concept of the teaching hospital. Those who defended this practice cited the fact that it most often occurs at teaching hospitals as reason enough to why it should be able to continue. They addressed the teaching hospital as implicit consent, meaning that by deciding to attend a teaching hospital, patients should have been aware of the fact that their bodies may be practiced upon. In contrast, those who were advocating for explicit consent suggested that patients might not always know they're at a teaching hospital, or there could be a variety of reasons why they attend a teaching hospital, meaning that it is still important to explicitly ask for consent for pelvic exams. This issue brings into question important concepts of intersectionality, as in the US, those who attend teaching hospitals are likely to be low-income patients and patients of color. And I want to emphasize that it's very important to problematize what choice means in a neoliberal framework, as most patients who attend teaching hospitals are not choosing to do so out of agency, but rather out of access needs and practicality. The next point I'd like to discuss is a fear of transparency when it comes to consent. This was probably the most sinister revelation of my entire research, in which I found that the most common argument made in defense of this practice is that if we ask patients for consent, they might say no, and therefore we shouldn't ask at all. This obviously makes a mockery of consent and reflects a stark lack of respect for autonomy and agency for AFAB patients. However, even when responding to this argument, opponents of the practice, and rather than upholding the importance of consent for respect, would simply argue and cite survey research that stated that most patients would say yes if they were asked, continuing to make consent conditional on whether the patient response would be desirable, rather than upholding a consistent ethic of autonomy and agency in the medical context. The next point I'd like to discuss is the relevance of the history of gynecology. This was not a point of tension within the literature, but rather a major gap that I identified. Throughout the literature, there was little to no mention of gynecology's origins, which are steeped in slavery and exploitation. This is important because these origins have led to a constant justification of abuse in the name of knowledge production. These colonial legacies have also created a normalized sense of ownership over AFAB bodies. I believe that until gynecology reckons with its violent past, a complete overhaul of the culture of medicine will not be able to be achieved. I'd also like to briefly discuss the findings of my legal analysis. About 20 states have banned the practice in the US, whereas other traction has died out or bills did not receive enough support. While legislation is important, the scope has not always been comprehensive. It's difficult to enforce. It also includes exclusive gendered language, and that's because this is a cultural issue. This has led me to conclude that consent regulations are important, but not enough. I believe that in order to enforce a cultural change, we must begin with overhauling medical education curriculums to better respect consent for all patients, specifically AFAB patients. In conclusion, I also want to emphasize that it's important not to let the attention to this issue die out. This issue has received media attention since the early 90s. There's been a few influxes of attention, but once the outrage subsides, little progress has been made. I hope that my project can keep this conversation active, as well as resist the medicalization of our bodies and the harm inflicted by flawed medical institutions. I support the argument for patient care, and I also wish to uplift the reasoning behind alternative methods of care. I imagine that we can create a medical system where autonomy and agency are prioritized, even in vulnerable situations where we voluntarily provide our bodies to our care providers. I envision a system where we can access healthcare without fear of coercion and violence, and can secure a sense of comfort and freedom. Thank you for listening.
Thank you, Maya, so much for your fantastic presentation on such an important and significant topic. We really appreciate the information you've shared with us, as well as the perspective you've brought to our panel today. And with that, we'll be moving on to our penultimate speaker, Marlene. So as I mentioned before, Marlene can't be here with us today. She's currently based in Australia. So instead, we have a little video that she has prepared and sent over. Marlene is a research student with an interest in healthcare student education and is primarily focused on how sex and gender is discussed in the student's education. And as for the rest, I'll let her take the floor. You'll just bear with us as we get the video shared and up and running. And in the meantime, I just want to remind everyone that we will have a Q&A session after. I know that we're running a little bit late, but we appreciate your patience and hope you stick around because our final two speakers are really something.
Hello, everyone. My name is Marlene Bruin. I am a research student at Monash University that's based in Melbourne, Australia. Unfortunately, due to time differences and prior commitments with my current project, unfortunately, I couldn't be there in current time. However, I would like to thank the conference for still allowing me to present my research. I really do appreciate it. My main focus of research is looking at healthcare student education. I would like to take a moment to acknowledge the people of the Kula and Garakani Nation on whose land I am gathered on today. I pay my respects to their elders past and present. My research topic is what are the experiences of gender sensitivity of an Australian healthcare student? I would also just like to note, you can probably hear by my accent, I am Canadian. I have been living in Melbourne for the last 2 years conducting this research, but I was actually from Vancouver, Canada. So I would just like to state that little fact about myself. Currently, the main tool used throughout research to look at gender sensitivity is sorry if I pronounce this incorrectly, the NIMN, Gender Awareness and Medicine Scale. This is definitely predominantly the scale that is used. However, it is important to note the scale was developed in 2007, so the terminology is quite dated, and even though it's still the predominant scale, my research team and I did not feel comfortable using the current version of it. So we made several changes to it, and this is something we did not just with my research team, but we consulted many external groups such as the Queer Collective at Monash University. We conducted and consulted many groups to make sure that we were including all people of gender and reframing the questions to include all people of gender. So that was something that was a heavy focus of this revalidation of the scale and changing the scale to look at and include all people of gender, because currently in the literature, much of the literature still has a heavy focus on the binary view of gender, and gender and sex are still used interchangeably. So the aim in this project was identifying how gender sensitivity is currently measured in healthcare student cohorts. And as discussed, I'll just be saying the NGAM scale is just less of a tongue twister for me. So thank you for allowing me to do that. So that was the first aim. We understood that. Then we went on to develop and change the way the questions were worded, and then we included the subscale, the change in transgender and gender diverse knowledge and attitude scale. This was actually developed last year. So in research, I started the project and the scale wasn't even published yet. So then by the time I was creating my scale and looking at even more scales, the scale had been published, thankfully, and I included that scale. So 38 students completed the survey. It's also important to note that there were 3 short answers at the end of the survey too, that students were able to give us feedback that I'll be discussing in the findings. And there on the last square, if you will, are some of the demographics. It's also important to note that this survey was also piloted with the new questions prior to the 38 students responding, with exiting students from Monash University. So they were not resurveyed in the both times. That's just also important to note. There was a pilot survey done. So unfortunately, because I'm not there, I just kind of created a bit of a, if anyone has further questions, I will walk through all of this, but I just also wanted to create something that everyone can reference if you want to read more about my results and the overall project. So the Nyman Gender Awareness Scale, the NGAM scale, was developed in 2007. Researchers developed a scale looking at gender sensitivity. However, as noted, this did not include gender diverse people or trans people, so we were very interested in changing that. The aim was to develop an appropriate gender sensitivity scale for all healthcare students. So that's something that also to note, that we changed it from medical students, whereas the NGAM scale looks at only medical students. We thought it would be appropriate to change to healthcare students so that it can better represent and be used. I thought it was a great opportunity to change, and hopefully this tool can be used in other cohorts to look at gender sensitivity. The scale has 4 subscales based on the original survey, 14 item gender sensitivity, subscale questions, So the demographics there are, if you're interested in reading about it, is there in the section methods. The results that were very interesting. The results within the study demonstrated medical students who identified as men had poor transgender and gender diverse knowledge and attitude scores. Previous results from the TGDKA subscale questions did not analyze results by participant gender and were conducted in nursing students. So after following up with medical students, we also did actually survey nursing students, which is great. That just changing that terminology from medical students to healthcare students, we were able to look at different and compare different cohorts, which I thought was very interesting. So the redevelopment of the scale was to better include and represent LGBTQIA community, and looking at how we can better support and include all genders and not just use the binary focus of gender. That was something that was incredibly frustrating to me, looking at the medical curriculum, whether that's, I've attended several different medical schools looking at sorry, correction. I haven't attended several medical schools. I've attended their conferences, and this is definitely something that's reiterated through many medical students, that they were quite frustrated that it was just being used through a binary lens, and that they wish that this is something that could rather represent all people of gender and not just the binary lens. Again, because I'm not here in person, I just thought that this was be a little bit of a better way for everyone to look at the information and look at the findings. If you have any questions, please feel free to reach out to me, and I'd be more than happy to answer any of those questions. I really appreciate your time, and here is my email if you wish to contact me. Again, thank you so much for your time and for allowing me to submit this video. Thank you so much.
Amazing. So that was Marlene's research, everyone. She did provide her email address, and we'll attempt to share it in the chat as well. So if anyone does have any questions, she is accessible. And with that, we move on to our final amazing, fabulous speaker, Chloe. So let me just get the screen sharing back up. I think everyone can see me. Yes, okay, amazing. All right, so Chloe Curtis is a PhD student at the University of Oxford, working between anthropology and women's and reproductive health. She has a Bachelor of Science in Anthropology from University College London and did a year abroad at the University of California, Berkeley. She then completed an MPhil in medical anthropology at the University of Oxford, and her current research explores hormonal contraceptive use in the contemporary UK healthcare landscape, specifically investigating what constitutes a side effect for those who use contraception, those who prescribe it, their measurement in clinical trials, and their reference in health initiatives and policy. We're so glad to be wrapping up our research panel with this wonderful talk. So Chloe, please go ahead.
Thank you very much. It's really great to be here. I'm going to get straight into it. So I'm going to be talking to you about the recognition or lack thereof of side effects from hormonal contraceptive use in the UK. Research for this was conducted about a year ago now for my research master's, and I'm now a PhD student at Oxford. I'm a medical anthropologist working between social sciences and medical sciences. So why is this research important, and what motivated me to do it? Hormonal contraception is thought to be the most widely prescribed drug in history, and it's estimated that there are over 100 million current users worldwide. Quite consistently, side effects and other health concerns are reported as the main reason why someone might stop using hormonal contraception. But unfortunately, we are still a bit clueless about what this really means. While there are a list of clinically recognized side effects, such as decreased libido, changes in bleeding patterns, headaches, or nausea, we don't really know how they affect people's everyday lives, nor why hormonal contraception might affect people differently. And over the years, side effects have been reported as a number of different things, such as minor, a matter of public hysteria, and a result of non-compliance in how they are used or how they should be used successfully. And often absent from any research is studying these side effects from the point of view of those who use them. So this is what I wanted to do. So I interviewed 30 individuals, all of whom had used one or more types of hormonal contraception, all from the UK, and there were some diversity within my participants. However, it should be noted that the majority of them were white British, middle class, educated to degree level or beyond, identified as cisgender women, and were mainly between the ages of 21 and 25. There were a number of different objectives of this research project, but today I'm just going to be talking to you about how users thought their experiences of side effects were recognized by clinicians and society. So the first thing that emerged was that they thought their side effects were unacknowledged. And I say unacknowledged, meaning that they might be listed on a medical leaflet, they might be clinically accepted, but those I spoke to didn't feel that they were acknowledged in their experiences. So a very good example of this is one of my participants, I'll call her Hattie. She developed a particularly unusual case of night sweats. And despite it being known that hormones play a role in the possibility of night sweats, Hattie explained to me that her doctors never questioned her contraception, and they had to rule out everything else first. After about a year's worth of medical tests, Hattie just decided to stop using contraceptives because she had a hunch that they might be causing her sweats, and they did immediately stop. Next slide, thanks. And some of those I spoke to, they also mentioned how their use of hormonal contraception was evaluated differently to other drugs. So for instance, at the time of the research, there were a lot of news about blood clots from the AstraZeneca vaccine for COVID. And this to the left is a post from a company called The Lowdown that showed the difference in blood clot rates, which they claim to be at least 50 times higher for combined hormonal contraceptive pill. So this is an example of some of the news stories that were circulating, essentially calling out how the AstraZeneca vaccine was being scrutinized for this side effect, yet accepted in certain types of combined hormonal contraception. Similarly, almost all my participants mentioned the absence of a male hormonal contraceptive, which they believed was due to the occurrence of side effects. And to the right is an example of how this was shared in social media. So while there may be some evidence of side effects, my participants felt that hormonal contraceptive was always able to evade investigation and side effects remained unacknowledged. Next, I argued that side effects were deemed as necessary, that they were collateral damage from saving the female body from its own chronic risks. And these risks might include things such as untimely reproduction, uncontrolled population growth, and fluctuating hormone levels. So one of my participants, I'll call her Mona, she said, I went back to 3 different doctors and none of them either believed me or they definitely thought that the worst thing that could happen to me was for me to get pregnant, not for me to have suicidal feelings. And when disclosing these suicidal feelings to her doctors, she remembers being asked about when her period was due. Now, I use this as an example to show that the possibility of side effects were constantly outweighed by other risks, such as the possibility of being pregnant. And so the contraceptive appears always as a saving grace. It will always save women from other greater dangers, and so side effects therefore become necessary. And this quite effectively continues to perpetrate an ideal of a female body as chronically risky and in need of treatment. Lastly, I argued that side effects became nullified in an environment of many contraceptive options, whereby if one does not suit, another is thought to be available. Side effects are only the result of a user not having found the right one in an environment of perceived choice. And indeed, since initial availability, multiple new types of hormonal contraception have become available. There's different types of administration, including, for example, a pill, a patch, an injection, an IUS. There's also different hormone contents. You can have a combined hormonal contraceptive, a progestogen-only one. There's also numerous different brands. So there's lots of options in order to find one that suits you and to find one that doesn't give you side effects. But while it seems like there's lots of options, most of my participants didn't feel this way. So for example, Jennifer, she said, I know the other ones are like injections or patches, but they're hormonal as well. So I think they'll have a similar impact. So for Jennifer, all these different types of hormonal contraceptives were the same one option. They were hormonal. And this was reinforced by many of my participants not being told about these different options by their doctors. Instead, most felt that they were automatically offered a pill and the one that they thought was the cheapest to the health service at that time. Next slide, thanks. This led to some of them taking matters into their own hands. So for example, Naomi, she did her own extensive research to find a hormonal contraceptive that she thought would work for her, but she struggled to access it. Her doctor had never heard of the one that she wanted, and he started Googling it in her appointment. When she finally got a prescription, she still wasn't always given this exact one. She said there had been a few times where they just wouldn't have it in stock, and instead they'd be like, oh, well, have another one with a similar hormone content. It's just a different brand. And so even to many medical professionals, these so-called options were very interchangeable. So in an era of contraceptive choice with lots of hormonal options, my participants didn't feel as though there were these options. They didn't know how to find the right contraceptive. They didn't think their doctors knew the options or the importance of finding that right one for them. So they felt that this perceived choice constantly nullified their experience of side effects because there technically always was another one out there, even if it was rarely accessible. So in conclusion, I found three main themes where side effects were unacknowledged, deemed necessary, and nullified in an environment of perceived choice. And we can't underestimate the numerous benefits of hormonal contraception, but I wanted to show how this narrative constantly eclipses and silences the possible experience of side effects. And this is from a drug that is still only available to those that are medically defined as female, and therefore puts a lot of onus and expectation on them. And just like to end by saying thank you everyone for listening. Thank you for Oxford for supporting my research, and to Medical Herstory for featuring all of us. Thank you very much.
Thank you so much, Chloe, for such a fantastic presentation on something that is so important that I'm sure all of us will, at some point encounter, even if not personally or for ourselves. So thank you. That was such a wonderful explanation and summary of your research. All right, so ending on that brilliant note, we'll now move into our question and answer session. And I am conscious of the time. I know that it's 1:09, but I hope people will stick around through our break for a few more minutes, just so we can answer a couple of your questions. If you haven't already, please feel free to drop them in the chat. And if we don't get to your question, as I said, you do have access to all of our panelists' social media or email addresses, so feel free to email them or reach out to them. And otherwise, if there are specific questions directed to individual panelists, maybe some of them will take the time to type out an answer in the chat. So for now, I'm actually just going to stop sharing and read out our first question, which is from Paulina. So as you were conducting your research, when coming upon frustrating or upsetting results in regards to sexism within your topic, how did you protect yourself from feeling frustrated or hopeless or helpless in your own private life and experiences? And we'll ask this to all of our panelists. So if anyone wants to take the plunge and have a go at it. Okay, Ellen, go ahead.
Yeah, thank you for thank you everyone for your amazing presentations and research, and thank you for the great question there as well. I'm sure everyone did, but I certainly found it can be so frustrating researching topics like this and really seeing sexism come into play. One massive benefit for me has been community. So I've been very fortunate, as mentioned, I am a volunteer here at Medical Herstory. So the community of the team really helped me throughout this research at times where I felt just discouraged and hopeless and will we ever make a change of this? It's so depressing. Having the team rally around and also being able to see actually, because my work as well did sort of focus on some things that Medical Herstory do, the findings will be able to provide real change. So that was something that really motivated me throughout it. But I'll pass on to someone else to speak as well.
Absolutely. Thank you, Ellen. Would any of our speakers, well, rather, which of our speakers would like to go next? Feel free to just unmute.
I can.
Oh, okay.
Sorry.
Chloe, Chloe, go ahead, and then we'll do, Victoria will go after.
I was just going to kind of reinforce that in saying that, when I completed research for this, it was during the pandemic. So it was it felt very closed off anyway from having that community, especially being a graduate student in a social science when you're very much kind of a lone researcher sometimes. So I think having a group of people that can give you some perspective on your research and make you feel kind of supported has been really nice. And for me now starting a PhD, being part of women's and reproductive health when so many more people are kind of aware of these issues, having people to talk to about that has really helped me to kind of to keep going and feel more motivated to make sure not feel as alone.
Absolutely. And I think that's something that all of us like at Medical Herstory as well feel, that even when we're looking at topics that can be, you know, very disturbing and upsetting, it's just so lovely to have a community of like-minded people. All right, Victoria, please go ahead.
Yeah, I think I really reiterate the same thing about just having a like-minded community around you. I found it very challenging being in a historical background because a lot of my fellow course mates were doing completely different things. And when I spoke about my research, they would often, the first question would be, what is endometriosis? Which is immediately quite discouraging if people don't even know what it is. So I found just making sure I had a community around me who really understood what I was doing was so important, and a good support network, and also a really good relationship with my supervisor. So I think, you know, when you're researching, whatever team you have around you or supervisor you have around you, making sure that they really understand you, and, you know, knowing that I could just go to my supervisor Lucy and just have a bit of a rant about the field was great. And then also I found reading research where people were actually making changes was really nice as well, so you don't get stuck in sort of that spiral of, oh, nothing's ever going to change.
Absolutely. Thank you, Victoria. Julia, Maya, is there anything either of you would like to add?
I would just say that I think for a lot of us too, as mentioned, like conducting this research with students, it gets very immersive at a certain point, like as you're trying to finish it up and graduate, and it kind of becomes your whole life. And I think that, and I mean, I loved it, I love the research, but I think that in addition to what other people have said about community and being with people, which was my main mechanism, just developing really solid other aspects of my identity that were beyond research about traumatic things, enjoying things around me in my communities or hobbies was really important to kind of create space for other emotions besides anger and hopelessness.
Absolutely. That is such valuable advice. And I think, you know, that applies whether it's in research or whether you're in the advocacy field or the nonprofit sector or whatever it is. I think it's so important to really force yourself. Sometimes it does feel like you're forcing yourself to take a step back and make space and time for yourself, to sit with yourself, to take care of yourself. So that's a super important and lovely reminder, Maya. Thank you. So I saw Julia kind of shake her head earlier. So I think the next question will get started with her if she doesn't mind. And so my next question is one that I think we all would love to know about all of our panelists today. And it's, what was the most surprising part of your research, or otherwise, what was like the most notable or challenging experience you had while putting together your research? And for Julia, you know, while putting together your beautiful artworks.
I think for me, one of the most surprising aspects was the different ways that people kind of engaged with some of the artwork. That was really interesting to me, and also as a more like personal engagement, as far as I referenced looking up all of the women that were featured on one of the art pieces, and just getting to read their stories and getting to learn more about them and their contributions, and how that like just how they led the field was really validating and encouraging for me, but also like having discussions about some of the artwork, and even simple discussions with like my mom, and having her not being a person who's in the healthcare field, and bringing up some of these issues that I consider to be very prominent, but she had never heard of before. So kind of sparking discussion in different spaces as well.
Absolutely. Thank you so much, Julia. Would any of our speakers also like to touch on this topic or this question? Go ahead, Ellen.
Well, if anyone saw Tori's keynote speech yesterday about what she found surprising in her research, I probably have the same answer, and it's similar to Julia's as well, is just how many people actually wanted to engage with it. The fact that this was a master's research project, the survey was only open for 5 weeks and I got 355 responses. It was just outstanding. I have to say, the first day the survey was open, I just kept refreshing it because it kept going up and up. It was so exciting. And my supervisor, again, he was completely blown away. He didn't expect, he'd never heard of patient advocacy before. I brought it to him with this project and he was just so blown away with the amount of people that wanted to talk about it and that experience it and had things to say and wanted to engage with it. So I think sharing there that the way that people actually do want to engage with these topics and that they are really important. They're maybe not just passion projects of ours, they do influence people. So that was definitely the most surprising finding for me.
That's so lovely. And absolutely, I think that's something that we all encounter. We really do forget how many people are invested in these same issues. All right, Chloe, Victoria, oh, Maya, wonderful, go ahead.
Something that was really striking for me in my research, and I do apologize, my research is obviously like a very triggering topic, so I'm going to be talking about assault quickly, was that how much assault and what constitutes assaults is so culturally coded and contextualized was really striking for me. It kind of reminded me of Angela Davis's work on abolition and how she discusses how in prison, sexual assault, well, what she deems as sexual assault is normalized because guards are allowed to examine incarcerated people whenever they want to, even in very intimate ways. And it kind of reminded me of how we treat doctors the same way, is that as soon as you exchange your education and put on this uniform, you're somehow allowed unfettered access to women's bodies or AFAB bodies whenever you deem is appropriate, but we don't recognize that as assault.
Yeah, absolutely, Maya. That is such like an important point and distinction to be made. And definitely that is really great insight. Thank you. Okay, Chloe, Victoria, is there anything you guys would like to add?
Yeah, I think the most surprising thing for me was when I was doing my oral history project. I only interviewed a couple of women, and I won't share too much because it is obviously confidential. But the therapeutic nature of being able to just sit down and talk about how a condition has affected your whole life really struck me, and it was so important. And I came away from all of those conversations feeling a lot of emotions myself, even though I wasn't connected to the participants, and I think it really speaks to the importance of being able to talk about your experience and having groups and avenues like this. So yeah, that was really striking for me.
Absolutely, Victoria, and I think that really speaks to how significant, important, and empowering storytelling can be, even if you're just bearing witness to someone else being able to reclaim and share their narrative. And for everyone interested, we will be having a storytelling event and workshop later today. All right, and so to wrap things up, just as she wrapped up our panel presentations, Chloe, would you like to share anything?
Sure, yeah. Yeah, in a similar way, like all of my participants I spoke to, it was at the end of kind of the interview, they'd always say this, if nothing else, it's been so nice to just talk, or kind of, as they would always say, rant. But seeing that kind of like therapeutic effect for them was quite surprising and really lovely. I think for me, one of the most kind of surprising things of my results is, which I didn't focus on in the talk here, is the effects that people thought hormonal contraception had on their moods, kind of linked to anxiety or depression, but also just in general, kind of more kind of emotional changes and moods and your sense of identity. And mainly because some of the kind of quotes and stuff were so descriptive and rich, they were really lovely. And the way that they could support clinical evidence that's just starting to come out a lot more now, that was really nice, because it kind of showed that just by listening to those who use hormonal contraception is just as powerful. We don't need this clinical data to to kind of like back it up, but being able to see those links between the clinical studies and what my patients were telling me was really quite like surprising and nice.
Definitely, that's so lovely. So thank you again, Chloe, Maya, Ellen, Julia, and Victoria for your fabulous presentations. I think we can all agree that having such diverse perspectives, diverse topics, and even just diverse disciplines, like you're all from different subjects, being kind of united under the umbrella of feminist health research is so wonderful to observe and be a part of. And we're so thankful to all of you for coming here today and taking the time to share your work with us. With that, we will take an 8-minute break before our next event, which is focused on storytelling. So I hope to see everyone back here at 1:30. We will leave the call open, but we're all going to turn our cameras off and take a step away from the laptops. Also, I do see that people are continuing to have a chat in the chat. So please feel free. If you did have a question that wasn't answered, like I said, you have access to our amazing speakers, socials, and emails. So feel free to reach out over there. But thank you again, and a little virtual round of applause for all of our panelists. Have a wonderful day.